Good afternoon, everybody. Welcome. The G-ECHO is hosted by the Gastric Foundation in association with Project ECHO, University of New Mexico. G-ECHO fellows run every Monday at 4:30 p.m. and the chat will be open for questions. Today's talk is on gastric cancer. It'll be interactive. I know that Matt Scriber is logged on and I will be asking questions for him. Is there anybody else that would like questions directed at them? If they have an interest in this topic, and you can let me know by either putting it in the chat or putting a hand up and I will gladly direct questions to you. But for now, all I know about is Matt. Are you there, Matt? Can you hear me? And you ready to go?
I'm here. Thanks, Lucien.
Hi, how are you?
Fine. How are you?
Fine, thank you. Okay, so in the absence of any other volunteers, let's start with you. So, right, just a little introduction. It's a common cancer, gastric cancer. Last time I gave a talk on esophageal cancer. Gastric cancer is even commoner and even higher, and it ranks even higher and as a cause of death, cancer-related death. And that's because the presentation is even later. The symptoms are vague, like weight loss, anorexia, abdominal pain. I mean, a lot of things can cause it. Whereas in esophageal cancer, the symptoms are more specific. So gastric cancer has got even a worse prognosis. The 20% 5-year survival is quoted globally, but it really depends on where you are, where you're from. So there are well-known risk factors for gastric cancer that most people know about. So most people know that older males get gastric cancer. But if you don't know, you know now. And that it's common in the East. Smoking and alcohol are known as risk factors. And then there are dietary issues that have been looked at, like, for example, lack of fruit and vegetables in the diet, or excess salt or pickled types of food in the diet. Then family history of gastric cancer. There is known family familial entities, but it's very rare. So less than 10% of patients that present with gastric cancer will have a family member that has had gastric cancer of any sort. And less than 3% of gastric cancers are truly genetically inherited. Okay, so the first question for you, Matt, is do you know of any genetically inherited types of gastric cancer?
Yes, there's a diffuse gastric cancer syndrome, familial syndrome, that I know a little bit about. And then there's an association with other genetic things that cause other cancers. For example, Lynch syndrome is the one that springs to mind. Things like FAP more likely don't really cause gastric cancer, they cause duodenal cancer, but Lynch is the one that can cause gastric cancer. Okay, you're right. The one condition specific to the stomach is the hereditary diffuse gastric cancer, which you correctly mentioned. And it is known to be caused by alterations in the cadherin-1 gene. Okay, I don't think you need to know much about it, but at least as long as you know, you've heard about it. But what important risk factor is not on the slide? Helicobacter pylori.
Infection. Okay. So H. pylori infection has been touted as a risk factor for gastric cancer. Now, my two questions that you have to answer, Matt, is does infection increase your gastric cancer risk? I mean, is there evidence that actually does happen? And the second question is, does eradication of H. pylori therefore prevent cancer risk?
I don't know about the evidence, but I would say yes, that infection does increase the gastric cancer risk. There's definitely an association. And I'm not sure whether eradication actually prevents gastric cancer.
Okay, how many patients with H. pylori infection do you think will get gastric cancer because they had H. pylori?
It's not as big a number as I thought initially. I think it's less than 20%.
Okay, right. So H. pylori is quite a weird phenomenon. So it's commonly found, and how common it is depends really on how hard you look for it. So in some places they look for it routinely, when they scope patients or or the patients have gastrointestinal symptoms. And in some places like locally by us, we don't look for it. We hardly ever look for it. So, but what we think is that it's present in half the population of the world. But less than 1% of infected patients will develop gastric cancer. Yet it's still considered a class 1 carcinogen by the World Health Organization. So you'd be right to say that most people believe that H. pylori will increase your risk of gastric cancer. But as you can see, it happens very rarely. So if it does, what do you think is the pathogenesis?
Well, I think it's linked, like smoking, those sort of things, to chronic ongoing inflammation and irritation over time that causes cell changes. If you look at the Courier hypothesis, for example, so that it undergoes changes, first metaplasia, then dysplasia, and then it lands up with an adenocarcinoma. So I think it goes along that pathogenesis line.
Okay, good. So it's how exactly it does, nobody actually knows. But what we do know is that it's a combination of an indirect inflammatory reaction and a direct, basically, effect on the mucosa, mutational effect on the mucosa of the stomach. And this is related to the virulence factors, the most well-known, which is the cytotoxin-associated gene A. That has been linked very strongly to different types of cancer caused by H. pylori. The vacuolating cytotoxin A has also been linked, but it's been linked to lots of other pathologies caused by H. pylori. But what we think is that these virulent factors work in combination with other risk factors that I mentioned in the previous slide, like smoking and alcohol, to increase your risk of gastric cancer. But that's only a hypothesis, we're not sure. The indirect inflammatory reaction, like you mentioned correctly, happens in a cascade, which starts with chronic active gastritis, then it becomes atrophic gastritis, which becomes intestinal metaplasia, dysplasia, and carcinoma. Why some patients will start with chronic active gastritis, end up in invasive carcinoma, while others, the majority, won't, we don't know. But we think there is some genetic predisposition to getting cancer from H. pylori. But these are all hypotheses, and we not 100% sure yet how exactly H. pylori causes it. Compared to other risk factors like smoking, alcohol, say like environmental risk factors, how high a stronger risk factor do you think H. pylori is? Say compared to smoking, drinking, diet.
I would think that smoking is more of a risk factor, I suspect.
Okay, so in this meta-analysis that was published in 2020, they found H. pylori to be the strongest environmental risk factor for gastric cancer, with an odds ratio of 2.56, much higher than that of cigarette smoking and alcohol. The other big one was diet related, but still none of them came close to H. pylori. So it does look like the answer to the question is, does H. pylori increase your risk of gastric cancer? I think the answer to that is yes. The answer to the second question of whether it prevents gastric cancer, you said you were not sure. Well, let's see what the evidence shows. The best evidence up to date comes really from this BMJ article by Ford et al., where they try to look at it as a form of meta-analysis. I'm going to just briefly mention another article where they also looked at it, but they used the risk difference compared to risk ratio, which I'll explain what I mean by. Now, when they did the meta-analysis, the first group found that, like the forest plot shows, that H. pylori eradication did prevent gastric cancer. However, it only seemed to do it in studies coming from the East. In this group of randomized controlled trials, of which there are 6, only 1 came out of the West side, from the West. Everything else comes from the East, so either China or Japan. And the one from the West didn't show any decrease in cancer risk if you eradicated H. pylori. So we're still not sure exactly the significance of that outside of the East. They also found that in the studies that looked at all-cause mortality, there was no difference using the same population group. So although the eradicated patients had less risk of gastric cancer, they still had the same mortality. The other study that I thought I'd mention is that most studies will look at risk ratio. What's the risk relative to patients who were not eradicated? This study looked at something different. They looked at risk, they were called risk difference. So in other words, is there a difference in risk of gastric cancer if you have eradication? And they found no difference in that. The group from Ford et al. Published actually a Cochrane meta-analysis, and their conclusions, which should be our conclusions, is that the data is still very limited, although it is moderate quality because they're from randomized controlled trials, but they only showed that there's a decreased risk in East Asia. There was no difference in one randomized controlled trial coming from outside Asia. So therefore, outside Asia, there's actually not enough evidence to show eradication of H. pylori will decrease your risk of gastric cancer. And when you say this decreasing your risk, you mean you're going to eradicate asymptomatic patients. And so therefore, it is not really advisable to put that as common practice now, and that's why we don't. And like I said, situation is quite different in the East, obviously. But do you understand now the role of H. pylori and eradication?
Yes.
Okay.
Yes.
That's clear. Okay. That was just about risk factors, but let's talk more about like clinical scenarios. Here's a case presentation I got for you. 63-year-old female, presented with dysphagia, weight loss, no comorbidities, good performance status. I did an endoscopy on her, and the tumor started at 38, went across the OD junction along the lesser curve, as you can see there, see mostly on retroflexion, and I took a biopsy, came back as an invasive adenocarcinoma. We did a staging CT scan for her. I've got only a few pictures I'm going to show you, and I want you to just look at them carefully. I'll go back over them again. That's all the pictures that I took. They're all, as you can see, basically coming from the abdomen. They're all only from the CT abdomen. Right, so the coronal views, and I would say that this one gives you the most information. What can you see on these scans? And I'm happy to move them, and from the endoscopic picture that I showed you.
Okay, so firstly, looking at the stomach itself from the views you gave me, the stomach isn't distended, so it's difficult to comment on gastric wall thickening, but it does look like there's more thickening proximally of the stomach compared to distally, which matches the endoscopic views. I can see a clear separation to, it was very quick, to the liver. I couldn't really comment about the vessels. I didn't see that properly. I don't see any liver lesions suggestive of metastases or peritoneal, obvious peritoneal lesions that I can see. I didn't see any ascites.
Oh, that's fine.
There was
yeah, sorry, go on.
And there was what looked like a mass lesion down in the pelvis. I don't know if that's part of the uterus or one of the ovaries or something, or one of the slides that looked a bit bad.
Okay, that's fine. I didn't need a full CT report from you because I know these are only limited views. But the reason why I said, okay, this one shows the most information because you can see here that basically that this is the proximal gastric wall and this is the distal gastric wall. And just comparing the two now, you can see that there's thickening of the gastric wall here with the lesion that you can see on the lesser curve. Also, how would you classify this tumor, knowing these CT scan findings and that endoscopic picture?
Well, I think there's many ways to classify it. You could use the CVIT classification here because it's basically a proximal gastric tumor. We say this is a CVIT 3 because the epicenter of the tumor is more than a centimeter below the Z line. And you could also say it's a proximal gastric tumor. The other way to classify it is TNM in terms of the staging. And there's also histological classification systems. So there's quite a few ways.
That's fine. That's good. No, I'm not staging. I'm just talking about classification now. So what histological classifications do you know?
The Lauren classification. Correct. Yeah, the Lauren one, which is very old, but our pathologists still use it. So in that one, you've got 3 types. It's intestinal type, diffuse type, and a mixed type. And then the more recent one is WHO.
Yes, and the WHO, correct. And then do you know any endoscopic classifications? Like the CWIT is anatomical. Do you know any endoscopic ones?
Yeah, I've just gone blank. I think there's a
Okay.
Borman classification as well.
Well done, Borman. Yeah, you're right. Okay. So you can classify these tumors anatomically according to the location. You can do endoscopic you can classify endoscopically according to Borman, and then you can classify histologically. So the anatomical one can either be around the outer junction or non-cardiac cancers. And then they are further classified according to SEWIT, and you're correct, SEWIT 3 is the gastric one. The endoscopic Borman one is either a mass, an ulcer, or it's diffuse infiltration, and then you correctly classified the Lorraine. It's still commonly used despite being old because it's quite simple. Now, the SEWIT you said 1 centimeter. Actually, we use 2 centimeters below as a SEWIT 3, and 1 centimeter approximately, according to the latest SEWIT classification. And the important thing about this is that according to the American Joint Committee on Cancer, they classify SEWIT 1s and 2s as esophageal cancer, and the SEWIT 3 is classified now as a gastric cancer. So they are treated as such. The Japanese use a similar classification to SEWIT, where they look at the epicenter of the tumor, like I say. So if it's beyond 2 centimeters of the OG junction, the true OG junction, which is then it's considered gastric, even if it reaches the OG junction. If, however, it is within 2 centimeters and it does not reach the OG junction or the Z line, then it's still considered a gastric tumor. And only the one that's within 2 centimeters and extends to the OG junction will be considered an esophageal cancer. So beyond 2 centimeters and within 2 centimeters but does not reach the Z line will both be considered gastric cancers. The Borman, like I mentioned, you must just remember there's either a mass, which is type 1, or there's an ulcer, which is type 2 and 3, or it's diffuse, type 4. And the ulcers either got well-defined margins or it's infiltrative and poorly defined margins. That makes it between 2 and 3. So if ever asked to classify, this endoscopic Borman, and that's how it looks. And then there's the anatomical one, and then the histological one. Obviously, you need your histology. Okay, so that patient I took to theater that I showed you. I did a total gastrectomy for her, distal esophagectomy. I managed to get proximal to the tumor from the abdomen, and I did a esophagogynostomy. And the histology came back as an adenocarcinoma. The tumor involved the serosa. 10 out of 20 nodes are positive. There were no distant mets on scanning or on my, my inspection of the abdomen, and all margins were clear. So what would be the pathological stage of this tumor?
I think this is a T3N3M0 cancer.
Okay, so right, so the latest TNM staging says T3 penetrates the subserosal tissue without invasion of the posterior peritoneum. As soon as the tumor penetrates the serosa, you'll have to call it a T4A, because the serosa is actually considered the visceral peritoneum.
Okay.
So it's difficult to tell whether it's T3 or T4 on the CT scan, but on histological examination, you should be able to tell. So that lady, she was a T4A, and then the nodes depending on the numbers, and you write it N3, and just remember the latest classification or staging changes. N3 is divided into A or B depending on how many nodes are found that are positive. So she would be actually a 3A. But otherwise, you were right, it was N3 and M0 is correct. That was staging. Okay, here's a second case for you. Right, this is a 58-year-old male. He presented with abdominal pain and weight loss. I don't have an endoscopic picture for him. He had an antral tumor on endoscopy that was biopsied, and the histology came back as moderately differentiated adenocarcinoma. Here I got some CT pictures for you again. I want you to look at them as I just scrolled through them now. This time I'm giving you axial views. Just have a look, and I'll go back up them again for you to see what you think. Remember the history. He had an antral tumor on endoscopy. Okay, let me go back up. So these are the only pictures. Once again, limited. I don't want a full CT report. I just want you to tell me what you see. I'm going to go back up.
Okay, I see thickening of the distal stomach, but it extends proximally as well. The proximal part of the stomach, especially on the posterior wall, looks very thickened, and I'm struggling to see clear planes. It's a bit difficult on. There are areas with a pancreas where there's quite a lot. It's quite busy in that area. I think there's nodes there as well, and for example, in that picture, there might still be a plane, but I'm struggling to see a plane with the head of the pancreas.
Very difficult there, correct? Well done. Okay, so right, so I can tell you that, like I said, I don't want a full report because we have access to the full scans, but there were some enlarged perigastric nodes. There were no distant meds seen. What is the next step in the management of this patient?
Yeah, I can't overtly call this irresectable based on that. And if the patient has a good performance status, then the next step is to take him to an MDT meeting. That's what I would do, and discuss his management. And I would advocate for, if he's fit enough, for neoadjuvant chemotherapy.
Neoadjuvant chemotherapy, okay.
And sorry, before I do that, sorry, I think in this case, sorry, I've missed the report step. I would do a staging laparoscopy first, sorry.
Okay.
Because I think this is at least a T3 tumor and it's quite big.
Okay, any other pre-operative investigations that you think you might need?
We've got an endoscopy, we've got a CT. I would do a staging laparoscopy. I think in some centers you might consider a PET CT. It's not something we do locally.
No, I'm asking what you would want to do.
I would do a staging laparoscopy. I can't think of anything else.
Okay, let's talk about staging investigations. All right, so these are all the options of staging investigations. And on these ones, according to you, you said we've got a CT scan. Other than that, you just want to go for a diagnostic laparoscopy. Okay, am I right?
Yes.
All right. So, okay, how useful are preoperative imaging for staging? Well, this group unfortunately didn't do endoscopic ultrasound. They just did abdominal ultrasound, which we know won't be great. So, as you can see, the important take-home points here is that MRI was significantly better than CT and T staging on their meta-analysis. The end staging between CT, MRI, and PET scan, the overall accuracy was equal. But however, the specificity of MRI of PET scan was much higher than the other two, whereas the sensitivity of CT and MRI was higher than PET. But that led to an overall accuracy that's equivalent. And then also, the overall accuracy of M staging was equivalent between CT and PET. But you can see that overall accuracy we're talking about, look at the CT scan, it's say the T stage is 70%. So that is actually very low. And the N stage even lower, 66%, and then the M stage goes a bit higher to 80%. And that's because of a high specificity that they have. But you can see that it will be very difficult to accurately stage a patient clinically with a CT scan alone. But none of these other non-invasive investigations actually add much. The EUS was examined in a meta-analysis, a Cochrane meta-analysis by this group, and let's see what they found there. So they found that when trying to differentiate T1 from T2 tumors, the EUS is actually pretty decent. It had a sensitivity of 85%, specificity of 90%, and it correctly, well, in a hypothetical cohort they found of 1,000 patients, they correctly classified 865. That's not a bad performance. However, when they try to go to differentiate between T1A and T1B, which now we're talking about submucosal versus muscular tumors, they found that the specificity started dropping. And the problem here that they found now is that you're understaging more patients. 75 out of this hypothetical 1,000 patients you'll be understaging. But it's still okay. The problem is the end staging. The EUS was terrible at end staging. Less than 70%. I don't think you can actually really justify using that to say anything. So that's a low specificity with many patients that would be understaged. So it was really best for differentiating between T1 and T tumors. The ones result that didn't show is when you try to differentiate T1 and T2 from T3 and T4, it is also equally good. So it's good for the gross things, but the CT scan could probably do that as well. Now, let's see why. So you said some centers will use PET. We don't use PET. Why do you think PET hasn't been uniformly or universally accepted as it has in esophageal cancer?
I think the main advantage with esophageal cancer is that esophageal cancer spreads to the lymph nodes in sometimes quite a haphazard way. It can go up, it can go down, and PET helps you to pick up distant nodes that might change your management. I think in gastric cancer, the lymph node spread is more predictable and is not as haphazard. And I think as your previous slides showed, PET isn't necessarily superior to CT scan at picking up those distant nodes. So I think it doesn't necessarily add that much more compared to esophageal cancer, from what I understand.
Okay. Well, the esophageal nodal spread is not necessarily unpredictable. It's just more complex than a gastric cancer nodal spread. So I wouldn't call it less predictable. This is the big problem. Most gastric tumors are actually not FDG avid. And that is why PET has underperformed in gastric cancer. And in fact, it's much worse if it's signet ring or mucinous cancers. As you can see with the World Health Organization pathological classification, there's a signet ring type and a mucinous type, and FG uptake is very poor in these cancers. And that's because mucin, they think the reason is that because mucinous is metabolically inert, so it doesn't perform as well. It is equivalent to CT for distant mets, and so there's no level 1 evidence to support its use yet in gastric cancer. So the routine use of PETs is not established, but that is the main reason, is that they found these tumors are not actually FDG avid. Now you mentioned diagnostic laparoscopy, which I think you were correct in it. So yes, diagnostic laparoscopy is actually very useful. So the CT will miss a lot of, and it depends on where you are, up to 44% of patients. But the caveats for diagnostic laparoscopy is, remember, you get the highest yield in T3 to T4 tumors, T3 or T4 tumors, in poorly differentiated tumors and tumors with a high nodal burden. When you start doing a subgroup analysis and looking at the earlier tumors, suddenly your yield from diagnostic laparoscopy is much lower, but that's to be expected, really. Now, the accuracy increased with peritoneal washings. So for the patient that are described, you said you do a diagnostic laparoscopy. Can you describe how you do it? Well, first of all, when would you do it? And then how would you do it?
I would do it for, I think most guidelines at the moment suggest T3 or above cancer. So firstly, so the first caveat is that you haven't already seen anything metastatic on the CT. I think if you've already gone down if you've decided the patient is not resectable on a CT scan, you're not going to do a diagnostic laparoscope. So that's the first caveat.
Yes, and don't forget, we're talking about the patient that you saw the CT scan of. So you know it's at least a T3, that tumor, because you could see the tumor was, look, there was a poor plane between that tumor and the pancreas even. So it's at least T3.
Yeah, okay. So I would then do it for a T3 cancer like that. I would also do it in a patient where the histology is particularly aggressive looking. So if it's a diffuse type, in a patient who's got, as you said, signet ring or mucin cancers, I think especially the signet cell ring cancers. And then I would also consider it in a patient that's got a tumor, if I'm not sure about the T staging, but it's crossing a significant part of the stomach. Gallia always says if it's crossing two gastric parts, so from antrum to body or something like that, then you should also consider it because they have an increased risk of peritoneal metastases. And in those where there's some ascites or significant nodal burden, I would also consider it.
Okay, then how would you do it? Describe what you do and when. Like, in other words, your timing when you see the patient, after you see the patient.
Okay, so I would do it. ideally before I take the patient to the MDT, once I've reviewed the CT scan, if I'm happy that the CT scan has been properly reviewed and we think there's no mets, then I would do the diagnostic laparoscopy, ideally before starting any neoadjuvant treatment, because you can change your management in a significant number of cases. How I would do it, obviously the patient's in theatre under GA, I would put in 3 ports.
Correct.
Do it a bit lower to where I would do a resection, because I want to look at the whole abdomen. So a camera port and 2 working ports. I would first have a look around to see if there's any obvious peritoneal nodes, any obvious liver lesions or ascites, and then biopsy that if that's there. If there's nothing, I would lift the left liver lobe and actually look at the stomach to see if I can see the area where the cancer is. And then other areas where you should look is at the ligament of Treitz, and ideally down in the pelvis, where they can have, for example, Krukenbergs in females, etc. And that's how I would systematically go around looking.
Okay, and then would you anything else you do at the time?
Locally, we don't. Yeah, we don't do peritoneal washing, but I was recently in Amsterdam where they do peritoneal washing. But the question is, what do you do if it's positive? If you don't see any peritoneal nodules or anything obvious, but you wash and then there's malignant cells in your wash, what do you do then? And in their practice, that it doesn't really change what they do. They still consider the patient for curative neoadjuvant therapy and possibly resection. They restage the patient then after that. So I don't routinely wash, but I do know the accuracy is increased.
Okay, so basically, yeah, they actually did increase. So the correct technique, like you said, you do it as a procedure you do before you decide on any treatment. You have to do it before treatment. And you're correct, just make sure that you say that when you inspect the abdomen that you will look in the lesser sac. So you have to check in there for any peritoneal mets. You must check the patogastric or patoduodenal ligament as well. Check there for peritoneal mets. Then you're right, you inspect the liver, like you say, the rest of the abdomen. With peritoneal washings, you must use saline to wash it. People use about between 150 to 300 mils of saline, and then you have to leave it inside while stimulating the patient. So in other words, moving the patient around the table for a few minutes, about 5 minutes, and then you aspirate from the pelvis again. Then this is now fixed with alcohol and a perpendicular smear, pap smear, and then looked at. Now, if it's positive for malignant cells, it's actually quite significant. Although a lot of people won't change the management, but it changes the stage of a patient, remember. So you want to accurately stage your patient when you start management for many reasons. And most importantly, for the patient itself, so they know what stage they're at. And if you don't see any metastases, but you get positive peritoneal washings, then it's called micrometastases. Now, micrometastases has shown to have a very poor prognosis. So you could actually also prognosticate your patient. But it doesn't mean, like you said, that you're going to actually treat the patient less aggressively, but it's something that you need to know. And the evidence for continuing aggressive management of patients with micromets is very poor, and in fact, almost non-existent. So people are doing it on an ad hoc basis, and the level of evidence will be level 4 evidence. So a lot of people would actually palliate patients if they get micromets, because like I said, the prognosis is very poor, and then you don't subject the patient to radical surgery or even radical chemotherapy. And the palliative options in gastric cancer, which we won't go in today's talk on, some of them can be quite aggressive in terms of the treatment, and that can impact on the patient's actual overall survival if given properly. So it's very important to know about diagnostic laparoscopy, how to do it properly, and peritoneal washings. Like I said, you must have a good cytology service as well, unfortunately, not always the case in many places. But that is the value of it. It's quite valuable. And in the center where you have everything available, you should say you will do them with washing. Okay. That's diagnostic laparoscopy. It's a separate procedure. study, a meta-analysis, showed it to have a good sensitivity of 85% and a specificity of is close to 100%. So as you can see, they had no false positives. So diagnostic staging laparoscopy is actually pretty good. The different societies differ in their recommendations. So sages from the USA will say T3 to T4 cancers. The Europeans will say all resectable gastric cancers, and the Japanese go to stage 2 or stage 3 cancer. So societies do differ in the indications for it. But then just to summarize the staging for gastric cancer, then CT scan will be done in all patients except for those that you are going to give best supportive care to. But remember, the accuracy is low. It's not high at all. I would only reserve endoscopic ultrasounds for if you suspect there's a T1 tumor on CT, and like esophageal cancer, you basically suspect T1 tumor if you don't see that tumor on CT. But the specificity is much too low for end staging. PET-CT is not routinely, it's not got a routinely established role, and staging laparoscopy, while recommendations vary, you would be perfectly when you're right to say you do it for T3 tumors and above, and any patients with node positive disease. Now, I just really want to get endoscopic management out of the way in one slide, because I can tell you that I've never seen a cancer that was amenable to endoscopic management, and I don't think I ever will. Like I said, they present even later than stomach than esophageal cancers to us. But also, once again, the recommendations for endoscopic management differ depending on where you're from. So in the East, they will be much more aggressive in their indications for endoscopic management, and these specifications come from European guidelines. So the Europeans will only do it if patient's got a T1A, no ulcer, a well-differentiated tumor histology, and it must be less than 2 centimeters. And I think it'd be safer if you happen to stumble upon a cancer at this stage that you can do this to, if you're lucky enough, to use these guidelines rather, because I think any more aggressive guidelines will only be applicable in centers where they're doing this very often. But basically, these pictures demonstrate how they raise the lesion first, mark it circumferentially, then start cutting with both these two knives until they get a circumferential tumor, which they then remove with the snare and subject to endoscopic evaluation. And if you get asked of which patients you do endoscopic management, just use these criteria, because these are purported by the European societies. But back to our patient now. Our CT scan shows he's T3 or T4, node positive, but it's M node. And you said now you diagnostic laparoscopy, you do, and there's no evidence of micromets. Now you take this patient to MDT, and they ask you, what would you recommend should be the management for this patient? What would you say?
I would say neoadjuvant FLOT chemotherapy.
And neoadjuvant FLOT means exactly what? How many cycles do you give?
So we usually give it in almost like a sandwich, so-called sandwich therapy. So you give usually 4 cycles pre-operatively, then you operate, and then you complete another 4 cycles post-operatively. That's kind of the standard, I understand.
No, that is absolutely correct. So which patients in general, let's add that patient, and I think that treatment of the patient is correct. But which patients in general should get oncological management as opposed to just surgery upfront?
Well, a tumor like this definitely should get it. So an advanced tumor, so T3, T4. The early ones, T1, which we never see. I think you can probably resect those up front, and then T2 falls in the middle and is individualized, but in most, I think T2 would also get, I would also advocate for neoadjuvant FLOT.
Okay, so you've already mentioned the treatment, right? There's a wide variation in practice guidelines. You're correct, go for T2 or higher. There's only T1 that you could justify not giving any oncological treatment. Okay, in the East, they give post-operative chemotherapy. I'll explain why. In Europe, they give perioperative chemotherapy, which is something that seems like the most widely adapted regimen. And in America, they most often give post-operative chemo radiation, and there's also a reason for that. Okay, so what does the NCCN guidelines say? Well, these are American guidelines, okay? Yet they say that they seem to support perioperative chemotherapy as a category 1 level evidence, which is the highest level of evidence that they can give. Whereas the other options are given as rather category 2 evidence. So they do say, and they say T2 or higher, and with any node of positive disease. So it's a treatment that but they also say that you can give post-op management if you do upfront surgery. And if you do upfront surgery, you must first make sure you had an R node resection. If you had an R node resection, then most commonly followed regimen in America is fluoropyrimidine, like basically either 5-fluorouracil and based chemoradiation. Because they found that the majority of surgeons actually in America perform a D1 lymph node resection or less even. And these are the most commonly performed regimens. Now, the reason why in the East they give post-operative chemo is because they routinely perform at least a D2 resection. We're not going to talk about the surgical aspects of management today because I was saving that for the second talk. So we'll talk about the D types of resection in the next talk. So the preferred regimens are shown here, and as you can see, the FLOT regimen, like you mentioned, is the category 1 evidence. So that one is the most commonly used one. According to NCCN, it's the preferred one. Yet, like I say, in America, where this one comes from, they don't actually use this most often. Most often they go here and they use post-operative chemoradiation for patients receiving less than D2 resection for some reason. Post-operative chemotherapy is the regimen used in the East. So if you go to Japan, you're going to get surgery up front, and then you're going to get post-operative chemo, because the patients are going to have a D2 lymph node resection, almost all of them. And they give also lots of different things. They've also got another type of drug similar to capecitabine, which they call S1, which they use very commonly in Japan, which is also a fluoropyrimidine. So there's different options, and you were correct in choosing the best option to choose is actually the perioperative FLOT regimen. How did it come about that we're using this FLOT now? Well, firstly, it started with a MAGIC trial, which was published in 2006. And in the MAGIC trial, they first showed that you can give perioperative chemotherapy and it will improve your progression and overall survival, progression-free and overall survival, compared to surgery alone in patients with gastric cancer, which was significant improvements. And then that was followed later on by the FLOT trial, which basically compared the MAGIC trial regimen to FLOT, and they found FLOT to significantly, once again, improve overall survival as well as disease-free survival. And that is why today the most commonly purported regimen is the FLOT regimen, which is a perioperative management. And it comes from this, these are the landmark or so-called management-changing trials. But if you say neoadjuvant chemotherapy, like you mentioned first neoadjuvant, and you meant given before and after. The correct term is perioperative chemo. Neoadjuvant chemo is given by some centers where they give the chemo, then they do surgery, and they don't give anything post-op if the surgery was an R node resection. And the meta-analysis of all the trials looking at the randomized controlled trials of the neoadjuvant therapy shows that there's an improved overall survival and progression-free survival when compared to surgery alone. So you can also do neoadjuvant chemotherapy. When you ask yourself, well, what is better between perioperative or adjuvant chemotherapy? So the perioperative is the before and after, and the adjuvant is only after. The trials seem to favor perioperative chemotherapy. But this study, which was called the Global Advanced Stomach Tumor Research International Collaboration Group, they love these acronyms in stomach cancer for some reason. There's plenty of them. Showed that any chemotherapy is better than surgery alone. So, and chemotherapy is the key to the improved survival in patients with gastric cancer. So even if you give adjuvant therapy, you will get better survival than surgery alone. But If you give neoadjuvant therapy, you'll get better survival than surgery alone, but the best at the moment looks like it's perioperative. The best trial probably, I mean, the best paper probably comes from this group from China, where they showed that they looked at a meta-analysis of all multimodal therapies, and they compared everything to perioperative FLOT, and they found that that FLOT actually outperformed every other multimodal form of therapy, including chemoradiation, which is post-op or perioperative, and they just didn't compare to the regimen that we use now most commonly locally, which is perioperative chemotherapy as FLOT. Okay, so you get that from in terms of the multimodal therapy for gastric cancer.
Yeah,
and that's T2, any tumor of T2 and above. Okay, now I've divided my talk into 2 talks, so I'll give the next one next time, which is an operative one, or surgical principles. So for this one, in summary, we talked about the risk factors. So H. pylori is considered the biggest risk factor at the moment, if you look at all of them. But eradication only shows to make a difference in Asia, not outside Asia. So we don't yet know. And let's say the jury's still out whether eradication will improve your risk. If you look at OG junction tumors, remember that anything with an epicenter more than 2 centimeters or within 2 centimeters, but not involving Z line, you should just treat as gastric cancer. And as you know now, it's different from esophageal cancer. The staging for CTs is overall very low. EUS is only valuable really in diagnosing, differentiating T1 from T2. This is where you really want it, and it's got a moderate accuracy really, rather than good. PET is not really got a role at the moment, and diagnostic laparoscopy you can use for T3 or node positive disease. Okay, multimodal therapy or management, the best one is at the moment looks like it's perioperative FLOT. But with all these meta-analyses I showed you, the problem is heterogeneity. So in other words, and the biggest factor leading to heterogeneity between studies with gastric cancer specifically is the surgery performed. So I mentioned in that one slide where I showed it in the East, they use post-operative chemo, and that's because they go in for surgery and they do an extensive lymph node dissection for all their patients, and they meticulously dissect the lymph nodes. In America, it looks like majority of surgeons that perform gastrectomy don't bother with performing a full D2 dissection, and even in their one landmark trial, which was done by McDonald, looking at adjuvant therapy for gastric cancer, the majority of patients had what they call a D0 resection, so they didn't even have a D1 resection. And I'll go to the surgical details in the next type, but if you think about it, it's probably because these patients had only partial gastrectomies rather than total gastrectomy, because it's difficult to do a full lymph node dissection if you're doing only a partial gastrectomy. It's really different, but we'll go into those the next time. So let's see. Okay, I was just thought there was a message or something, but it's not really. Okay, so in summary, then the algorithm goes: look, you do your staging CT, okay, and if you got M1 disease, then we'll treat as such. The other thing we're going to talk about in the next talk is the management of M1 disease. But if you suspect T1 disease, and I said before, it's the patient where you don't see anything on CT scan, you should do an EUS for those patients only, which if it confirms T1A, then you can do an endoscopic resection. If the endoscopic resection or the EUS shows T1B, then the patient should have surgery. So anything going into the submucosa should have surgery. And in surgery, if there's positive lymph nodes, then you should at least give post-operative chemotherapy. Some people will say, well, why don't you give radiotherapy? There's not enough evidence to say that radiotherapy post-operatively would be better than chemo, even if you did upfront surgery and you've got positive nodes. The other two is either a T2 lesion or a T3 versus T4 lesion. If you got a T2 lesion, so really, the only way you could find this, the CT scan is it's not so good at differentiating T2 from T3 and T4, is you're going to have to do an EUS for those patients. So if you happen to find that patient you should give perioperative FLOT with surgery. And if the surgery was resulted in an R1 or 2 resection, then they're going to need chemoradiation then. But if you had an R0 resection, you continue with your perioperative FLOT regimen. And like you said this correctly, it is 4 cycles, surgery, 4 cycles. That's provided the patient can tolerate it. It's quite hectic chemotherapy, this, and not all patients can tolerate it, and not all patients end up getting the post-operative one. Anything from T3 and above should have a staging laparoscopy first. And obviously M1 disease, like I said, we mentioned before, but if there's nothing, if the staging laparoscopy is negative, then you go on and treat like the T2 disease with a perioperative FLOT. That is the algorithm that you should follow. And that is the end of part 1 of gastric cancer. Do you have any questions, Matt, firstly?
Lucien, thank you very much. That was excellent as usual. I just want to ask, what do you actually do? Do you wash when you do your lap scope? And if there's micromets, what do you do in Maritzburg? Do you then palliate the patient?
So no, like you, I don't wash either. But the reason why I was talking about the washing, the evidence shows that you should wash. So for me, I might actually start washing soon. The problem is our cytological service is very poor. You need a cytopathologist that is good with gastric cancer, and that's what they have when they do these studies. So it's very different in real practice. But what you must say is, and I've asked, if you find a micrometastasis on washing with a diagnostic laparoscopy, then you treat that patient as M1 patient, which is not necessarily palliation.
Okay.
But it's M1 disease, which like I said, we'll talk about in the next talk. The next talk will be on the surgical principles and M1 disease specifically.
Okay. All right. Thank you very much.
But the point is you have staged the patient differently now. It's not it's an M1 patient.
Okay.
Which is very important. Okay. Yeah, no problem. Anything else from you, Matt?
No, nothing else. Thank you very much.
Okay. Anybody else in the audience have any questions? Okay, if there are none, then hello, was there a question there? No. Okay, anyway, if there's none, then I'd leave me to thank the ECHO UNM and ECHO India team for the support. Feedback is available.
Dr. Ferndale.
Yes.
Thank you for a wonderful presentation. I'm Henny from Endoscopic, one of the registrars.
Hi,
Is it possible that you can just go back to the T1 slide on your algorithm of treatment?
Okay. This one.
Yes, yeah. I just wanted to see how the endoscopic ultrasound has an effect, but it's just to differentiate between 1A and 1B.
Yeah. So the T1A is the only one you can treat endoscopically. T1B has got the risk for lymph node metastases are too high. So those patients require surgery.
Thank you, doctor.
Sure. Okay. Let me go through my slides again. And yeah, as I was saying, to thank feedback is available on the chat, and recordings are available on the Gastric Foundation website. And thanks to the Gastric Foundation. And next week's talk on the 5th of September will be on pancreatic cystic neoplasms by Dr. Burmeister. Okay. Thank you, everybody, and have a good evening.
Thank you.
Thanks, everyone.